So our next speaker is Dr. Robert Herkes. Robert is the Clinical Director of the Australian Commission on Safety and Quality in Healthcare. He's an experienced clinician, a leader in intensive care. He was the previous Director of Intensive Care at Royal Prince Alfred, State Director of the New South Wales Organ and Tissue Donation Service, and Chair of the New South Wales Critical Care Task Force. He's going to address us on what we know about health and economic benefits of trials and registries in Australia. Thank you, Robert.
Thank you, John, and thank you very much to the organising committee for inviting me. It's a bit daunting speaking after Neil and Mark, so now I've done the same thing. So what I want to briefly talk to you, and I'll speed through some of these, a little bit of the work around data that the Australian Commission for Quality and Safety in Healthcare is producing and what that might mean for you to use, what a self-improving healthcare system actually is. The Commission, funded by the Commonwealth with ACTA, has done a cost-benefit analysis of clinical quality registries, and I want to present you some of the data from that. We've also done a prioritisation for clinical quality registries, and lastly, a cost-benefit analysis of the clinical trials network, all of which are showing significant potential savings were quality care to be implemented in all our hospital settings and our primary care settings. Now, I was lucky enough this year to have a holiday. And back when I was a medical student, I visited this thing. So anyone here who's under 30, that is called a library. And in the olden days, when I went there last century, my camera didn't play music. My camera couldn't be used as a torch, and my camera didn't have more information at my fingertips to look up than the whole of that library. And I put it to you, we're at the same sort of tipping point here in health. What we're starting to do in Australia, after a long lead time, is use data to drive care. And that's what these things are, they're data tools, and that's what wasn't there last century when I first visited that beautiful library. Just incidentally, Oxford University was developed in 1096, and the Doomsday Book preceded that by 10 years. Apparently, while I was overseas, there was a census. Probably we'd better not talk about that. The Commission's a weird organisation in that it's a co-ag funded, so it's a bit like the Federation. 50% of our income comes from the Commonwealth Government, and the other 50% comes from the states and territories on a cost share basis. So we're responsible to everyone. And we really are here to support initiatives to improve patient care, and everything we do has really to be patient focused. And sorry, I'm going to flick through all these to try and catch up a bit of time. So anyone who works in a hospital or in a day procedure centre or in a dentist surgery will be aware of some of the work of the Commission because we set the National Safety and Quality Healthcare Standards. We've done work around pricing for safety and quality with IPA through hospital-acquired complications and through best practice pricing. And we set these things called clinical care standards, which are the front end of what ICHOM does. We write a standard written for junior staff, doctors and nurses in the middle of the night, what a patient would expect, and then write specs for how you might collect data about your practice to work out how your practice is performing. So sort of the actual intellectual bit before you start collecting data about, say, acute coronary syndrome. I'll just flick through these. Just for your information, the health service standards are just finished consultation. There's a new version coming out to decrease duplication and to put in a new standard called comprehensive care that looks at all the things a patient would expect when they go into hospital. So our hypothesis is that measurement's fundamental to advancing healthcare and healthcare improvement. And when you look at that, there are lots of different, the beginnings of different measures within Australia to look at care. So there's an atlas of clinical variation. There's extraordinarily important work lots of you are doing around clinical trials. There's clinical quality registries. There's hospital-acquired complications. There's standards indicators. There's sentinel events, and so on. And what we really need to do in Australia is to start to hook together all these measures and feed them back to frontline clinicians and make them transparent and available to patients and their relatives to drive quality in the system. Now, many of you will have seen the first Atlas of Healthcare Variation. Darker colours means higher rates, and I have to admit that yesterday I drove through the eastern suburbs of Sydney, but managed to avoid having a colonoscopy miraculously. So, one of the important works that we've been doing is looking at clinical quality registries. And back in 2010, the Commission published a framework for clinical quality registries that talked about a governance structure for the registries, how the registries might report, how it might analyse. And really a clinical quality registry is to provide severity of illness adjusted outcomes with peer comparisons to frontline clinicians. Now, one of the things we've tended to do in Australia, particularly in primary care, is average everyone's, say, use of antibiotics and feed back to an individual GP their use of antibiotics versus all their peers. And the problem with that is if there's groupthink and everyone's high, you look good against your peers, even though you might internationally be terrible. So the great thing about clinical quality registries is it works on a model to look at adjusting severity of illness to try and adjust between the variables in people's practice and feeds it back to the frontline clinician. So what is a clinical quality registry? These are funnel plots out of ANZIC's core, publicly available. And there are, as you can see, for funnel plots, you're supposed to be within the funnel plot. Here, for instance, in an aggregated risk-adjusted model of chronic obstructive pulmonary disease in patients through an ICU, these hospitals that are above that top line have excess mortality. Now, what does ANZICS, the clinical society, do about that? It has an outlier management process that, with the jurisdictions, goes and looks at those hospitals and those ICUs to work out whether there's something wrong with the data, whether there's something wrong with the way the patients are being cared, whether there's something wrong with resourcing, but looking at the units to try and improve those outliers to get them down to the mean. Now, you notice this is using an international adjuster. The graph would be significantly higher, and most Australian ICUs would be low outliers because our mortality in ICU is better than the international models suggest it should be. Similarly, here's a ACORN registry, which is a registry looking at knee and hip prostheses, again publicly reported. On the two graphs on the primary hips on this side and primary knees on the other side, pre-op difficulty of walking. That's severe difficulty of walking, pre-op, for patients with primary hip replacements. This is severe difficulty of walking for patients with primary knee replacements. So that's pre-op, and the second column is 6 months post-op. Very significant patient-reported improvements in outcome. Now, this is the sort of thing patients want to see. If you're going to have a knee replacement, you want to know what's the likelihood that my severe disability is going to improve after my knee replacement. And again, we're starting to be able to show patients this data. This is data from ANZOD, the Australian New Zealand Dialysis and Transplant Registry, looking at graft survival for renal transplants by decades between Australia and New Zealand. And you can see very significant long-term, this is 10 years post-transplant, graft survival, very significant, about 75% now graft survival at 10 years for renal transplants, and patient survival well over 75% now, 10-year patient survival post-renal transplant. Extraordinarily important data for the system to know, extraordinarily important data for individuals working in transplantation to know, but also for the public. So we did, with Health Outcomes and with ACTA, an evaluation of clinical quality registries. And in fact, we looked at the Prostate Cancer Registry, the Victorian Trauma Registry, ANZICS, ANZOD, ANZData, and the National Joint Replacement Registry to look at what the costs of running those registries were and what the benefits were. And the data was extraordinarily conservative. So, for instance, in the ANZICS one, we looked at the outlier units that had outlier intervention and looked at the rate with which they improved after the intervention to see how long it took them to come back to the mean, and costed the value of that. So it was very, very, very conservative. And in fact, as you can see, overall these registries have a cost-benefit analysis of over 5:1. Now in Sydney, building the West Connect has a cost-benefit ratio of 1.2:1, okay? These are 5:1. So very, very, very economically justifiable. But the most important thing is it improves patient care. Now that report will be on the Commission's website on the 2nd of December. It's just been approved for release. Next, we prioritise registries, and I'm just going to flick across this, looking at patient disease, at patient burden, at system burden, to try and work out a list of important registries if money were to flow towards registries. And as you can see, the list there is the sort of things that you would expect to bubble out of that sort of analysis. And then thirdly, the Commission's done some work about working with clinical trials networks to do an economic evaluation of clinical trials networks. And again, we found significant positive returns on a benefit-cost ratio. There are substantial benefits for patients, and there are extraordinary benefits both Australia-wide and internationally were the results of these clinical trials to be promulgated to the whole of the system. So we looked at 3 clinical trials networks: the Australian Stroke Trials Network, the Interdisciplinary Maternal and Perinatal Clinical Trials Network, and again ANZIC CTG. And this is way too small to read, but these are some of the substantial publications out of those networks. They're all essentially Lancet, New England Journal of Medicine or equivalent, so they're world-class results. So significant international impact. When you look at the cost-benefit analysis of the clinical trials, again, very, very, very significant benefits versus costs. And in fact, 9% of the gross benefits of the trials that we studied would cover all of the NH&MRC funding given to clinical trials networks in Australia between 2004 and 2014. So amazingly high benefits to costs out of the trials. And again, the most important thing is better patient care. So the hypothesis that Mark put to us, that in fact improving patient care improves cost, there's some reasonable evidence here, both on the basis of clinical quality registries and on the basis of clinical trials, that hypothesis is justified. Now, I'm just going to show you a very historical thing. My first job as a junior doctor, as an intern, was with an extraordinary surgeon called Tom Reeve, and he was an endocrine surgeon, and he was about to retire. And for the whole of his surgical life, he'd kept these things called edge-notch cards. And he had every single patient he'd ever seen on an edge-notch card. And what you do is you notch these holes if the patient had a condition that hole is coded for. So if it was a thyroidectomy, he'd do a notch there. If it was a carcinoma of the thyroid, he'd do a notch there. And if it was they had a post-op bleed, he'd do a notch there. And if they had post-op infection, and so on. And just by using cards and a needle, Tom could look, and you could go to him and say, Tom, how many thyroidectomies have you done for carcinoma of the thyroid over your whole of your working life, and how many of them had a post-op surgical bleed that required return to theatre? And he'd put the needle in and smash the microphone and pull out the cards, and the cards that were left behind had that condition. Then he'd put the next needle in. And so he'd filter every patient he'd ever seen on these edge-notch cards. So I put it to you that we're about to do edge-notch cards for the whole of the system. And it's really exciting and it's really important. And I'd like to encourage you all to go and look at the Clinical Quality Registry's outcome cost-benefit analysis when it's published. And I'd like to encourage you all to continue to supporting registries and to continue to support clinician-initiated clinical trials within networks within Australia, because it really is important stuff. Thank you.